Pharmacogenomics is the technical term for the way that individuals respond to medicines depending on the genes that we've inherited. Now, this has the potential to save a lot of money because you can match the right person with the right medication. But for people with cancer, it's much more than just cost. You need to get the treatment that will work and to kill the cancer before the cancer can kill you. So pharmacogenomics is giving us a way to work out before treatment which cancer medications are likely to be most effective for which patients.
My interest in pharmacogenomics is in identifying who benefits from what therapies in such a way that we can tailor these therapies more closely to individual patients. But you have a disparity between technology that's very far evolved on one hand and real-life clinical practice on the other hand, where patients don't yet have access to these new technologies. So what we're trying to do is build a bridge between the two. This is not about the cost for the drug, and it's not necessarily about the cost for the assay or the test itself. This is really about the costs that are associated downstream, the medical cost with the complication of the medication that you have just been prescribing.
The challenge is to be able to more accurately identify people who will experience complications from their medicines, or those in whom the medicine won't be effective.
This is very important because I believe that once a drug already has been approved, we don't necessarily measure well enough what's actually happening in that post-marketing environment. Because if you think about it, that's really the largest trial in itself. So if we were to find better ways with registries, for example, to follow patients over time, monitor their outcomes, you may indeed find markers that are creating subpopulations for which we can better tailor the drug in the future. So it's almost a little bit like a learning healthcare system where we don't just say, okay, something is approved, now go, do it, but we continue on that learning curve.
Not only are we failing to learn from real-world outcomes by monitoring how medicines perform in real patients, it appears we're not using the opportunity to identify potential problems before prescribing life-saving medicines.
When we set out to do that trial of about 1,000 doctors who we called up, only 2 or 3 have heard of a genetic test for warfarin. And mind you, this has been after the FDA has updated the label for warfarin with genetic information, and it has been written up in the Wall Street Journal, in the New York Times.
So how do we change doctors' awareness so they consider whether genetic testing will provide information about individual patients to better target the medicines they prescribe?
That's a very good question. What we do is the infrastructure that we have access to allows us to, in real time, identify patients coming to the pharmacy who could benefit from, let's say, a genetic test for warfarin. So we can call the physician at the point when the patient comes to the pharmacy and inform the physician about the availability of such a test and ask whether or not the physician thinks that it might be useful.
In the future, will we be mapping the genes of babies so that the information is readily available?
Yes, I believe so, very much. I think that, as I mentioned in the beginning, the advancement in technology are so rapid that we're getting very quickly to the point where testing, or actually whole genome sequencing for babies, or every one of us, makes a lot more sense than paying for individual specific tests that would actually cost a lot more. So what's important about this is that we're building the infrastructure to capture that information, store it, and be able to retrieve it at the point where it becomes useful.